All right. Trippy.
Closer. Trippy?
Yeah. Trippy. Yeah, that's the right word to start with this one, right?
Trippy.
Yeah. Trippy. Dr.
Trippy.
Simi Rahman. How's it going?
Oh my gosh, we're live?
We are live. We had some technical difficulties and we had to
Yeah.
we had to get the mic set up because but the thing is you sound super nice and clear now, so this is perfect. Because I want to be able to hear everything properly because I'm totally high right now. I'm kidding, I'm not. But anyway, we'll go ahead and start. Everybody who's joining in. Okay, wow, there's a bunch of people viewing it. So thank you, everybody, for joining. So here we are. Are ketamine and psychedelics the future of mental health treatment? More and more people are using ketamine therapy for treatment-resistant depression, anxiety disorder, PTSD, acute suicidality. Recently, and I told you about this. We had Elon Musk had an interview with Don Lemon. It was pretty contentious. A lot of it was comical for other reasons, but he talked about his own prescription ketamine use with Don Lemon, and I felt like Don Lemon was a little clueless about what it really means. So, but I haven't introduced you yet. So for the audience, Dr. Simi Rahman is a board certified physician, pediatrician, psychedelic medicine practitioner, and medical director at Palo Medicine in Pasadena, California, which he co-founded with psychedelic integration coach Rob Matthews. And you're here with us for about an hour. Thank you for your time to help us understand how to evolve our thinking around mental health and mental illness and the current state of research around psychedelic medicine, ketamine therapy, MDMAs, psilocybin or magic mushrooms, microdosing, and hopefully, I think we're probably going to get into a lot more. And because there's been a wide interest, a lot of interest in that many of you have shown in this topic, we're doing this live right now, and Dr. Rahman has generously agreed to answer your questions as we stream. So feel free to go into wherever you're watching this, if you're on YouTube or Facebook. Put your questions into the chat and we'll try to get to them at some point. I can't guarantee that we'll get to everything, but we're going to try to get to whatever we can. As for this is the 10th episode of this new podcast. It's called Unlicensed Therapist. My name is Ali Rizvi. This is a platform where we dissect the human experience in the 21st century and explore how we think, how we relate, and how we believe. So this is actually quite apt for this. I'm very excited about this. Simi, welcome. Thank you very much for joining me.
Thank you so much, Ali. Oh my goodness. It's wonderful to be here. It's a fantastic topic. Yes, we have to do it live because if you record it, you miss the opportunity of the moment. We're kind of in a be here now moment. We're being invited to really look at something in a really expanded way that we've never done before, that really calls into question our ideas, our understandings of reality, even our capabilities as humans. So yeah, I think it's a perfect topic for this podcast. You're hitting it right on.
Yeah, that's great. And speaking of dissecting the human experience, so there's a lot of parts of this that I wanted to talk about, and we're going to get into it. One is what happens, the brain, the sort of the neurological part of it, and then also the experiential part of it, the human experience part of it. So we're going to try to get into both. I want to get into the latter a lot more, but just to start with you. So you are you're trained as a pediatrician. Obviously, you're also, you're a physician, you're a psychedelic medicine practitioner, you're a medical educator. You coach medical students at USC on topics ranging from burnout to health justice. You're a narrative medicine expert. So you do workshops with patients who undergo this kind of treatment. How did you? This is a pretty varied career. How did you make the switch from going from sort of pediatrics into mental health and then specifically into the sort of psychedelic medicine?
Fantastic. Thank you for that introduction. It really brings to mind for me that it's been a journey. It's been a journey to this place that probably started from the first time I started asking the question, why? Right at the age of 3, like, why are we here? Which we all do at some points. Traveled with us through medical school, which is where we know each other from, where we marveled at the human body and how it functioned. And as the more we found out, the more incomprehensible it seemed. And here we are at this phase of existence. And so I went through pediatrics, which is all about childhood, human development. I did a master's in medical education. So I really delved into what learning, specifically in the medical field, but learning in general, what human learning is about, because I just kind of love that stuff. I really looked forward to learning something outside of medicine for once, because you and I both went to med school when we were 17. So
Yeah.
right, so we kind of backed into all of our other interests in some ways. And so really it has felt like breadcrumbs, as I look back. I'm like, all of that was leading me here, because
Mhm.
here you go, in psychedelics, you open up a critical period of social reward learning, which is something that we're finding out through the great work that Gul Dolan is doing. This researcher in a paper published in Nature just blew open the lid of like, what is happening? Oh, the mice are actually opening up a critical period of learning in their brains, just like the critical periods we have in human development when it comes to language, when it comes to movement, when it comes to abstract thinking, right? We all go through those stages in predictable ways when we're children. And when we're adults, we think that that's it, no more learning can happen. We have some
Mhm.
theories about the fact that the adult brain can actually learn very much. And here we
Yeah.
are at this place of looking at the brain after a psychedelic journey and seeing that there's actually a new critical period opened up of learning. And you can actually inculcate new thoughts, new habits, new behaviors, new worldviews, new perspectives on relationships, a new relationship to yourself. I mean, you can really just hack your brain to learn what you need to survive now, right?
Yeah.
Just like kids, develop, like one day you're not walking and the next day you are, right?
Mhm.
Um, and part of it is also interesting. Like the toddler age for me as a pediatrician was very interesting because it's the time of most rapid brain growth. And that's when you can kind of imagine where a toddler's like, yesterday I couldn't do this. Today I can. This is freaking me out. So that emotional response that we get from too much change, right, is also something that kind of happens. Like a toddler's having a bad trip in
Mhm.
some way.
Yeah.
And if we understand what's happening in a place of transformation and rapid change, and we support it, what we're doing is we're allowing the person to learn, allowing their brain to take that learning, encode it, create new behaviors and a new framework for their world, and how they interact with it. So it's just a fascinating thing. So you can bring in even storytelling, right? So narrative medicine was that next thing that I did, which was like, okay, let's look at stories in medicine and how do we tell ourselves stories? And, there's this idea that we get stuck in a story and how do we get ourselves out of it, right? And
Mhm.
I did a lot of that work for myself, going through my own trauma work in the last 10 years, having gone through divorce and career change and things like that. And for me, learning was kind of, it went hand in hand. Whatever I was learning, I was applying to myself, to my residents, to my medical students, and really understanding, and even going back to our experiences in medical school, right? It's like,
Mhm.
why were we thriving? What were the elements that made us thrive, and just looking at that. So I was very fascinated by what happens to people in environments when they get together and they need to learn something. And how can we do that? So I would conduct workshops to kind of get people into flow states. How do you
Right.
get into learning flow state? How do you understand, it's not just lectures, it's actually active learning.
Yeah.
So all of that brings me to this place where psychedelics seem like the molecule that kind of unlocks, gives us a shortcut to the same place of engaging with your stories, learning new thought patterns and behaviors, going through a new period of development, just like you would a child. So it's almost like I could say that for some reason, I have arrived at this place of connection of all of these three bodies of knowledge.
Mhm.
And I love the clinical work. It's really been amazing to kind of bring it all together so I can support my patients through it. And it's been amazing for trauma work. It really has. So
Yeah.
I think that's why there's so much interest in psychedelics, right? Because it's just we're in a place of trauma right now in the world of and scratching our heads as to how are we going to manage all of this? We don't have a system.
I think,
Um,
yeah, that's the thing. So it's about how to approach trauma. I mean, trauma's obviously existed for a very, very long time, as long as human beings have. But it's really but thinking differently about it. So again, the brain part of it, you're talking about being able to um, sort of evolve the brain anatomically the way that we do, like neuroplasticity, right? That's what we're talking. So ketamine, the way that, for example, we're going to be talking about ketamine, we'll be talking about other psychedelics as well, or psychedelics in general. So ketamine works in the brain by modulating glutamate, which is, well, it's an amino acid that helps build protein, but it's also a neurotransmitter, and ultimately it modulates glutamate in the brain in a way that leads to synaptogenesis, or let's say with the creation and development of new connections between neurons, right? The cells of the brain. So can you talk a little bit about the audience? And again, this is, a lot of them don't have backgrounds in neurology, medicine, and so on. And can you talk a little bit about the process in a sort of simpler and more brief way for listeners to understand and touch on what we mean by neuroplasticity, like what you're saying and how that's related to this learning in adulthood that can mimic the way that we learn in childhood?
Yeah, yeah, absolutely. I mean, we're trying to make those connections, right? Is what's happening in the lab and what's happening in our brains, and how are we
Mhm.
translating that into behavior? And so there's multiple pieces of information that you want to put together when you're trying to create a model of how ketamine is working in the brain. And one model is to think of treatment-resistant depression, right? So treatment-resistant depression, what they see in the treatment-resistant depression brain is that the number of neurons, the number of connections is lower than you would have in a normal brain. So
Right.
it's kind of like a pruned bush, right? It's got some connections, but not a lot. Okay, that's one piece. The second piece is the connections that are there. What's the quality of them, right? Because those connections are the ones that are causing the ruminative thinking, the despair, the sad thoughts, maybe the suicidal ideation, maybe even the self-loathing. Like there's just a whole lot of thoughts and ideas that are circulating in those connections, right? In that, you know, in that brain. And what they found, and this is from Robin Carhart Harris's work on the kind of energy distribution of the brain and its connections, is what ketamine and these psychedelics are doing is they're hitting a hard reset on the energetics of the brain, So it's like, it's creating this, I really do describe it as like, a kachink on the CPU of your brain. You just, the energy pattern used to, before the reset, kind of travel in this one particular map. The map could show you that there's more energy going to these kind of ruminative, the grooves, kind of that, of maladaptive patterns of thinking that are in the brain, right? And so once you have the reset, what they found is that the energy kind of matrix of the brain gets resettled, and it gets less sticky to those ruminative grooves, and there's more energy available for other pathways to form. So what you're literally doing is you're kind of shaping the energy distribution of the brain so that it's less sticky for negative thoughts. And so people do describe that. They say, I've my self-loathing voice went away, or when I have a trigger that usually would send me into anxiety, I find that I have a little space from it. They
Mhm.
have a little out, just like in the heart when you have a heart attack, and if you have the kind of watershed effect of lots of connections, you're more likely to survive a heart attack, right? Because you've exercised, you've like built up those extra pathways. So even if one little part of the vasculature uh, clogs up, the others can kind of take care of it.
Yeah.
Similarly, creating alternative pathways in the brain that get stronger and stronger, and that's where the neuroplasticity effect is coming in. So ketamine goes in, works through glutamate, the AMPA receptors. You get a surge of BDNF, or brain-derived naturopathic factor, which literally grows those dendritic connections between neurons. They're seeing this
Yeah,
in the
the dendrites are like the finger-like processes that come out of the neuron at that. Yeah, at the
that are the actual connections, like the
yeah.
synapses. Now you've got this bush that used to have less connections and less branches and less leaves, all of a sudden starting to form new connections, to actually have new um, fingers of neuronal tissue kind of trying to touch each other, right? And so
Mhm.
you have what that translates to is behavior change, thought pattern change, even a change in a sense of self. Because all of a sudden, I'm not this depressed person. I'm a person who actually has alternative ways to think about myself, not
Yeah,
always. Mhm.
I think that's the thing. The difference between a lot of the other treatments and like SSRIs and SNRIs and some of the other antidepressants, for instance, or anxiolytics, um, and this really is about a change in the way that we think. It's rather than just a change in a feeling good effect. It's more than just a feeling good effect. It's actually, when they say it's a transformative shift. And I wanted to ask you, like, just relating to that, how should we now think about mental illness, right? So over the last century, we had the Freudian thing where everything we thought about it as psychogenic. We had Freud, you had childhood, our relationships with our mothers, and so on. And then we moved on to the biochemistry and the neurochemistry of the brain, where these disorders now are seen primarily as sort of neurochemical imbalances in the brains, and we do still see it that way. A lot of the treatment is based on that premise, and then we have the genetic basis for these illnesses, and that also came about where we saw hereditary patterns, right, and certain genetic predispositions to things like depression, anxiety, even tendency to like behavioral things like substance abuse. And now here, you're talking about modifying the whole process of neuroplasticity and literally rewiring the brain and its connections. So my question to you about this is something like depression, is it a disease in and of itself, or is it just like the symptomatic manifestation of a kind of more foundational sort of underlying process, where
Mhm.
depression is just a symptom of an underlying process? Does that
Yeah,
make sense? Yeah.
absolutely, absolutely. Like, you've laid it out really well. And I think that's a really, um, I think, very important question, because we all think of mental health in this one framework, right? We all have this way of, and it's culturally determined, it's scientifically determined. There's lots of ideas that build the model in our brains.
Mhm.
And when we talk about these questions, we're kind of engaging with a dualism, right? It's like, is it either this or that? Is it genetics or environment, right? We say this or that. And
Yeah.
here we are kind of sinking into this question of, what is depression, right? What is depression? Is it something that I'm born with? Maybe. Is it something that happens to me? Maybe. Is it something that happened to my mother or my grandmother? Maybe. Is it something that is in the environment that I'm living in right now that's causing, some of those tendencies to line up and creating the conditions for depression to then express itself, right? I mean, you
Mhm.
look at what we do when we're testing all of these SSRIs that you mentioned. What's the model for depression that we use? We use this drowning rat model. So we basically put rats into a near drowning situation, and that's the model of the depressed brain that we use.
Waterboarding rats. Okay, this is excellent.
Waterboarded rat. So literally what they're saying is, your depression is kind of like you're a waterboarded rat. And not only are you a waterboarded rat in this generation, but you're a waterboarded rat across like the 20 previous generations, because we're talking intergenerational trauma, we're talking genocide, we're talking migration, we're talking all of these things that through epigenetics now is something that you inherit, right? And so when we talk about depression, I'm again brought back to the example of a shrub, a tree, right? What happens when you put a full grown pine tree into like this tiny little bit of soil, and grow it into this very beautiful bonsai tree. It's still a genetically able to fulfill its promise as a pine tree, right? A full-grown
Mm.
pine tree. We put it into conditions where we create a much smaller version of it. So in some ways, what we're saying is that depression is in some elements partly environmental, and we can talk about inflammation. We can talk about gut brain health. We can talk about the environment of just constant stimulation that we're living in right now, that is really just kind of using up all of our resources, right? You talk about neurotransmitters, like we weren't supposed to be, kind of constantly in a cortisol state, flooded with neurotransmitters, being, you know, uh, physiologically kind of in this hyper regulated state without being able to come back to base, or without having also, let's not forget about it, a society and a culture that supported us, right? And that's, I think, where we really get into this discussion with psychedelics, is if we're treating psychedelics just kind of like this wonder drug, and we're ignoring all the other aspects of, just what surrounds a human being and leads to depression, and the kind of downstream effects of depression, we are not doing, anybody any kind of favors. What we're doing is we're creating more depression while we're also treating it. It just becomes this churning machine. And, let's talk about housing. Let's talk about, air quality. Let's talk about a living wage. There's all of these things that really come into play, which is why psychedelics are just such a fascinating topic, because it really gets to the health justice issues of who gets to have access. People in Silicon Valley and the billionaires, they've been doing psychedelics for years. This whole story is not about them. This
Mm.
whole story is about those who've been marginalized, criminalized, sometimes even, did time for exactly the same molecule that we're not going to legalize, right? And
Yeah.
so, right, like it's the war on drugs. We had thousands of patients going through LSD research in the 50s and 60s. Nixon came out with the war on drugs in order to criminalize Black and brown bodies, right? In
Mhm.
order to create this framework in which access to mind elevating drugs were not just shut down, but used to, criminalize a group of people. However, access has continued. Silicon Valley very much has boasted that a lot of the kind of advances that have come in technology have been kind of attributable to these altered states of consciousness, because in these altered states of consciousness, creativity goes up. You sometimes, there are studies that have shown that when you take people who are working on a really tough problem, like a scientific problem or a creative problem or something that's just, it's a big project that they're working with, and you give them psychedelics, they're more likely to come up with a solution.
Mhm.
And so this becomes a problem solving technology, right? Like there's all of these compelling kind of possibilities that become very real. And then we have to kind of step back and say, well, who is it becoming real for, and who's it being left out? And that's where, we are right now in this kind of environment with psychedelics. So that's a long
Yeah.
answer to.
No, there's a there's I mean there's a stigma on mental health. We talked about that. And now there's this specific treatment, which is turning out to potentially, and I know that there's a lot more research that needs to be done, that just turning out to be potentially even more effective than most of the other conventional treatments right now we have for these illnesses. So and that's another thing. Look, and what are the questions that people are going to have? And now I want to kind of get into the personal experience, what people actually go through when they undergo, specifically what you do in your clinic, which is ketamine therapy. But the first question is, look, people can feel good with any drug. You do drugs, you're gonna feel good. You're gonna do cocaine, heroin, you're gonna have a high, you're gonna feel on top of the world a little while. It doesn't solve the problem. Okay, so and you've already talked about like at least the well, the neurological side of it, how this actually does have lasting effects. But just from an experiential part of it, well, first of all, let's see your patients. They come into the clinic. Um, what do they come with? How are they referred to you? How do you get these patients? And then how do you evaluate them? And how does the process begin?
Absolutely, absolutely. So just to kind of before I talk about the process, yeah, there is a potential for addiction in ketamine. It is a street drug called
Mhm,
Special K. The misuse of ketamine or recreational use of ketamine, I must say, has gone up in Europe and other places.
mhm,
So this is all happening in the context of that story too, so people who have problems with addiction, specifically for ketamine, this is not something that I would recommend to them. But
mhm,
these medications are also psychedelic medications are also good for um, healing from addictions. And we can talk about why that is, because there's a real good reason for it. And it goes back to our friend Johan Hari,
mhm.
and
Yeah.
how he talks about disconnection and addiction, right?
Mhm,
So, to go back to your question of, is this just like a feel good drug and you come in, you feel better, and of course, your life's going to feel better? No, actually, people are a little bit frightened when they come in. They're scared. It's anxiety inducing, because this is not just a I'm sitting here, I'm feeling good, everything else is fine, and I just kind of cut myself off from my reality to get a bit of relief. This is I went deep into a therapeutic process into my own psyche, and
mhm,
it was difficult. There were parts that were scary, there were parts that were blissful, and, all of that is possible, and there's no way to predict. So when people come, I do a really good, thorough intake. I ask them why they want to do ketamine therapy. How have they heard about it? Have they seen other people? Have they had bad experiences with ketamine? Because you want to get all of that out there, because people have had bad experiences. Ketamine has traditionally been known to be have the side effect of a dissociative kind of.
anesthetic.
It's a dissociative anesthetic. But what happens when we give ketamine in the hospital, in a dissociative anesthetic, in the setting of, let's say, an emergency room that's just cacophony, beeping monitors and everything, and you put somebody into a psychedelic state without preparing them, they're going to come out of it kicking and screaming, because
Yeah.
what just happened to them while they were on that psychedelic journey, they have no explanation for. Nobody
Right.
prepared them for it. Nobody prepared them to think that, oh, you might feel like you're stuck in this kind of space for a while, but only 20 minutes have passed, you know? So time, right? Like preparing them even for the time dilation that can happen. There's just a lot of things that go into preparing somebody. So I talk about all of these things. I really ask the person to tell me, what is your deepest intention with this? What would you like to see happen in the next 1 to 2 years in your life that um, we could bring into this space? What are you carrying? You know,
Mhm,
um, what are you struggling with every day? And ketamine is great for giving us that a rapid antidepressant effect, the neuroplasticity, all of that. It just opens up a opportunity. It opens up a container. So I always frame it as it's a tool. It's a tool
yeah.
that we use very intentionally, just like other psychedelics have been used for millennia, intentionally held in a very safe way, meaning that we don't abandon somebody after they've been in a ketamine journey, or judge whatever comes up while they're in the ketamine journey, because when we talk about holding safe space, it means you could do whatever your process is. You could cry, you could scream, you could laugh, you could just have a deeply cathartic experience, and we will hold that for you. We will hold
Mhm,
that with you. We're not going to reject you. We're not going to say, oh, that's too much, you can't do that here. And there's this interesting thing that we've trained people not to be themselves. In the
yeah.
healthcare industry, we're very much like, well, don't do this, and don't offend the doctor, because then they won't treat you. There's just all of this kind of power differential that happens in healthcare, which I feel like in psychedelics it's really important to acknowledge, because it puts the person in a vulnerable state. So as a psychedelic practitioner, I'm really looking to build trust, engage with the person, hold really strong boundaries for myself, but also realize that this is a co-created therapeutic space. This is not me telling you this is the dose you need, this is going to help you, and da 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 da. I can guide you on the dose. We can go at the pace that you're ready, but this is a co-created space of healing, which is a really it makes it dynamic, it makes it interesting, it makes it creative almost, and it really honors the person's autonomy. And
Yeah.
that's really what we're doing at the end of the day. Is we're telling people, yes, you are carrying all these things, but now you have the capability in yourself to walk with it.
Yeah. And before we go on, I just want to talk about the approval status of this. So ketamine as an anesthetic, as a dissociative anesthetic, has been in use since, I don't know, 50 years, 1970, 71, something like that. And then there is with the nasal spray, and I forgot the name of it.
Bravado.
Yeah, so that's a ketamine derivative, and that is indicated right now for treatment-resistant depression. Just that right now, and then there are, like, psilocybin, which is magic mushrooms, and MDMA, which is like Molly, ecstasy. That is FDA approval for that is anticipated over the next, I think, 2 years or so, or a year and a half.
So the FDA has to give us some sort of indication by August of 2024, actually. Although we did get some kind of neutral news today, which we are still processing. It's a very active space of, opinion. Today, the news came out that the FDA approval process is kind of either at risk or being slowed down because there's this report that there was maybe on the part of the therapists, and this is a really contentious note, that there was expectancy bias, that there was kind of like this overwhelmingly positive, kind of spin put on things. I mean, just the way I've been talking about it, right? In a research study, and I wrote about this on LinkedIn today because this is so fascinating, because in a research study, what you're testing is the molecule. In a psychedelic study, what you're testing is the molecule interacting with the person, right? So when we in a purely pharmaceutical study, what we call the placebo effect is something that we discount. And in the psychedelic experience, the placebo effect is actually called the inner healing intelligence. It's seen to be a part of you that is there, that has your best interests, and that is able to lead you towards, to guide you towards healing. And so when we bring up this notion of, what's at work, like what is happening here? The molecule is just facilitating this experience, but there are signatures to this experience that are common between psilocybin, ketamine, ayahuasca. Some of these things have very similar signatures. And so what is happening in these states that goes to this kind of deep sense of what it means to be human, even,
Yeah.
so that's a really difficult thing to study, so research, so that's what's happening today, as of today. But the approval is expected by August of 2024. And so everybody's kind of scrambling to see, like, how are we going to administer this? How do we even we're talking about the medical model here. So that's one aspect. And the other movement that's going through in different states, and Utah has actually pulled forward with putting forth a psychedelics bill, where they just decriminalize psychedelics, on a state level.
Yeah, there are. So I think that there's also a question of how it's given, right? I mean, there's different. You have to be in a treatment center. There are cost issues. There are logistical issues. You want to have a medical team around you. I don't think. I mean, at least from most practitioners I've heard, they do not recommend. How they send the ketamine to people in the mail and they can have the experience on their own. Like, that's not the way to go about it. It needs to be sort of guided and supervised. So I think there's a lot of aspects to it. But so, and the indications right now, so what conditions do you find it, which the patients that you have, what conditions do they have that you decide to go ahead and that you would find it effective in?
Yeah. So Good question. Treatment-resistant depression is probably the most well-studied. However, there's a wide number of diagnoses that are being kind of tested, including anxiety, PTSD, OCD, substance use, specifically alcohol use disorder, as well as eating disorders. And so there's just this kind of we're trying it with all of these disorders, and it kind of goes to the point that all of these disorders are kind of connected at their root.
Yeah.
All of these are just expressions of what really comes down to it, which is this disconnect from self. These mental health disorders can make us feel isolated, tell us a story about ourselves that is not true, that is, harmful, that can make us just feel disconnected. And as primates, we need connection. We need to be held within a network of our fellow beings. And because of the way we live these days, I mean, really, that connection is ruptured for a lot of people. And so we're really in that space of talking about what are the diseases of disconnection and how do we heal without actually, what do you call it, pathologizing the person.
Mhm.
Because whatever the label is, I'm dealing with what is it that you're carrying. At a certain point, I'm actually not even concerned how much is ADHD and how much is this and how much is that, because really that's brought about by the DSM, that's brought about by the need to fit in our mental health disorders into the SSRIs, and the FDA approved categories for the SSRIs. However, that's just a mechanistic way of really, in a very simplistic way, I think, of looking at all of these disorders, which really at the base of them have some form of disconnection, either disconnect from self, disconnect from your kind of, the resilience that you might have, disconnect from your body. In chronic PTSD and anxiety disorders, we see a lot of physiological upregulation, right? So we see
Mhm.
heart rate, blood pressures that are really high. And after ketamine therapy, what people notice sometimes on their trackers is their blood pressure and their heart rate has come down,
Mhm.
because an anti-inflammatory effect also that ketamine is having. So,
Oh,
yeah, it's a really fascinating molecule that is literally just sitting in plain sight and has been understudied. And here's the industry kind of running after this MDMA and the psilocybin and trying to figure that out, while we have a rapid onset anesthetic that's been known for over 50 years, that is safe to administer in office
yeah,
settings.
tested for decades. Yeah.
Yeah, we've been
Um,
it's given to children,
that's, hmm.
it's a fascinating kind of weird schizoid world we're living in. I'm just gonna take a sip
Yeah.
here. A bit
Yeah,
more.
yeah, go for it. And there's a lot of the questions piling up too, and we're gonna get to the questions because there's a lot of really really good questions. Um, so these, yeah, one of the things is, so the question for you, and you can feel free to take the fifth on this. You have you had experience with ketamine yourself?
Yeah, so
Okay,
this space is very different in that if you are going to become a practitioner in it, it is actually recommended that
that
you
you
do
do
your
it.
own psychedelic healing work, because this is the stuff where you could read 1,000 books on it, but unless you experience it, you don't know what your patients are going through.
Yeah, yeah.
Yes, I have.
And so one of the things that I hear, and I'll also say, a very very long time ago, um, turn of the century, the last century for all you kids. Uh, yeah. So I did. It's only one time, and I was probably too stupid to register any of it at that time. But there is one thing that I do hear a lot, and I think that is unmistakable is, so we've been talking about connections, we're talking about neural connections. There's a weird kind of and again, this is very hard to explain, so I'm probably gonna and ah a lot here, but there is a sense of, even though it is supposed to be a dissociative anesthetic, there's a really the only thing I can say about it is there's a really stark kind of mental clarity, but for me at least, the physical part of it, like I would think I was moving my arms, but I wasn't really. And so it didn't, I felt maybe a little disconnected from my body. I felt a little disconnected from, your thoughts and your memories. Again, this is very hard to explain. Your thoughts and your memories, you feel sort of separate from them.
Mhm.
You can observe them, but it just seems like, okay, well, I can, yeah, see, I can't explain it. So
You did it.
does it make sense? But there is a sense of connectedness, like, we're all, what you feel with other things too. You feel the sense of connectedness with everybody else. You're like, okay, we're all in this together. A lot of the things we think are very important in our normal, non-ketamine lives don't seem as important. And a lot of the things that have been really kind of weighing you down, they still exist, but you feel a little separated from them, actually quite separated from them, and you can actually see them in weird things. And I think that's also another thing. I was it's called synesthesia, right? I think I could sort of see sounds. And I remember we were listening to Iron Maiden, then it was a heavy metal band, Iron Maiden, and you can actually see parts of the music. Again, this all sounds very trippy by definition. But so that experience, but I think that idea of feeling connected, yet at the same time, very clearly seeing things that were very connected to you. Like, you can sort of experience things without necessarily feeling them in a bad way. So anyway, after that big hodgepodge, can you just guide us through what patients feel when they come in, when they don't? Because there are people who have come in for, specifically talking about sort of ketamine therapy for treatment-resistant depression, who've tried everything, multiple suicide attempts. They're just completely intractable. They've done all of the different treatments, done talk therapy, they've done the SSRIs and all that. And then they have this ketamine therapy, and just within one treatment, and then later on, maybe a few more, it's completely transformative. I mean, I see people just saying that it saved my life. Like, I wouldn't be around if it wasn't for this. So,
Yeah. And,
go ahead.
and just let people know that, there is hope. And, this kind of, when we talk about self-harm and suicide, I just want to make sure that people realize that, when we talk about it, please feel free to disconnect when you need to, if it gets too much. But it is real. It does happen. The suicidal ideation. They're actually doing a study at Rady Children's right now. One of my colleagues was able to get it approved at a much lower dose, actually half the dose that we use in the clinic. They kind of had to fight through and use it in adolescents who are ending up in the emergency room with suicidal intent and suicidal attempts. And, our system basically gets clogged up at that level because we don't have any place for the number of people that are coming through. So the potential of ketamine, when used in a targeted way, for some of these really intractable conditions that we before didn't really have good answers for. I mean, ketamine is only
in
thought
the acute phase, right? So in the
and ketamine is thought of in the same breath as ECT, which is electroconvulsive therapy, and transcranial magnetic stimulation, TMS, which are, therapies that are approved when you're in treatment-resistant depression. You've tried a couple of SSRIs and they've failed, and so ketamine is put in that end of the train, right? The caboose. And here we are going, it's a rapid antidepressant. It's safe. Why would you not use it right at the beginning? And so what we're really confronting right now is changing the mindset, around this medicine and how it's used in the system, right?
You're right. So, I mean, I know people say that there's a lot more research that needs to be done. And I get that, obviously, but you're right. Like, this has been, like, when you're talking about giving it in a supervised state, and we're not talking about, people doing it in their house and, we're talking about people having it done at a treatment center, medication that has been used extensively, like every endoscopy and colonoscopy and everything, like since whenever. And the safety has been studied, tolerability has been studied. It's been used in children, used in adults, and now it has research does demonstrate, right? It's not only its therapeutic effects, but actually, what's happening at the sort of the molecular anatomical level with it, and so it is. I can see how there's a little bit of trepidation when people get too excited about something and paint it as something amazing when there are clearly downsides. So, and I know that happened with marijuana a lot. People, the cannabis, legalized cannabis, the best thing ever. It's natural. It's incredible. And people didn't really have a balanced conversation about it because it became kind of politicized. So I understand how skeptics may look at that and say, okay, this conversation isn't really going the way that, we would, that would give us some kind of confidence in this.
It got politicized and I got monetized. Those two words.
Yeah.
It got politicized and I got monetized.
But
and that's that's coming down the pike for psychedelics as well.
Yeah.
But,
so yeah, I think it's good. But I had a question. I guess the next question I was going to ask, and we do have we have a neuroscientist in the house, Zainab Fatima. She's also known as Dr. Z. She's she's got her own she's also done a lot of work on what you were talking about in terms of like learning in adulthood, adaptive learning and so on. I don't know, hodgepodging everything. But she's saying, so how many sessions on average do most people undergo to see better quality of life outcomes? So we're talking about how even the first session can make a huge difference.
Yeah.
But overall, how long do patients stay in treatment with this?
Such a good question, because when you kind of going back to a little bit to frame what you were saying earlier, the phenomenology of the experience, right? What you were describing, the disconnect to connect. When you were talking, I really kept getting this phrase, disconnect to connect, because you're in a dissociative anesthetic. However, there's more connections happening. What is that all about? So let's talk about ketamine a little bit in the perspective of its different levels of therapeutic efficacy, because it's not just all one thing. So we're finding is that there's low, medium, and high, right? There's low, medium, and high doses. There is a stepwise fashion in which people go into the ketamine journey. So what you experienced at first, you kind of see your thoughts kind of unspool a little bit, whatever you're carrying. You can kind of see your own thoughts from a third person perspective. You can really experience music. And I really want to talk to you about the music piece. So if I get a chance, you can have that synesthesia. You can have a deep sense of warmth and relaxation is what happens when people first step into it. So it's kind of like a loosening, relaxing, letting go of everything that you're carrying. Just imagine it's kind of like the anteroom that you're entering into, and all that you do in the anteroom is just let go of your everyday thinking process, and that is correlated with the default mode network, relaxing. Right. Default mode network is that sense of I, me, the centered self. And once that starts to relax, there's actually a stage of anxiety that comes up, because as you can imagine, the erasure of the sense of self can feel like I'm about to die. Right. So there's a stage of ketamine at which you get to a near-death experience. Or can you
go into that a little bit more? Because I think that people who haven't experienced, and this includes me, that's something I didn't experience, but I've heard a lot of people talk about it, the erasure of the sense of self, or what people say, that this idea that we have of the self, I guess, we are in our bodies, we're looking out through our eyes at the world, and we're a consolidated entity that's in our body. But that sense of what we think of as the self becomes fragmented, or is it
not fragmented? I'd actually say that it dissolves, and that's a difference, because as long-term meditators will tell you, the self is not real. The self is a constructed element. The self of, when it disappears, it's not like you disappeared, you're still here. It's just that you gain a sense of expanded self, which means you can feel like I am the universe. The universe is me. I am one. It's like that non-dual experience. So the duality goes goes away, so we're kind of in this philosophical space of even asking, who are we? What kind of beings are we, that we have the ability to step into this non-ordinary state of consciousness. And Aldous Huxley explained it really well in his book The Doors of Perception. It's cleansing the doors of perception, which really goes down to the idea that we all have this capability. I mean, throw the molecules out. Once when the molecules were, kind of outlawed, Stan Grof came up with this whole kind of breath work, method of getting to that same psychedelic space called holotropic breath work.
Mhm.
And so we have the capability of, through breath, changing our chemistry enough to dissolve that boundary, right?
Yeah.
One of the things that people say is that, when people have quote unquote a psychotic break, or are having hallucinations or delusions, especially in younger kids whose brains are probably a little bit, more kind of pliant in this way, that is basically the brain's ability to get into a non-ordinary state without any, without any external stimulus. So it's the interaction of this is a really strange kind of space, and I know that it's probably not going to make a lot of sense unless you've been through it. So what kind of is happening is the sense of self is dissolving. The sense of being connected to everything kind of opens up. There's a lot of explosion of kind of joy and bliss and connection. People describe a warmth. People describe that, I'm able to connect with emotions I haven't been able to connect with in a long time. Now imagine what that feels like in a depressed brain, right? Like you've only been able to see maybe 3 colors in the spectrum for maybe 20, 30 years. And all of a sudden, the full range starts to open up, and you can kind of remember what it felt like to not have a depressed brain.
Yeah, I was watching a documentary on this, I think some time ago, and they described it as having like 40 therapy sessions all in one go, where I can't remember what it was last year, but I think there was this one. She was a journalist who was and a sort of a medical professional who went in with her mother
Mhm.
and experienced this, and she said they were sort of emotions that I didn't know that I had, that she was able to kind of express and communicate to her mom, that she hadn't been able to do in years and years of therapy. So yeah, so it's interesting that it has, what you're talking about, that's sort of the acute experience of
Yeah.
while you're having it. Now, once you're done and you're out of the treatment center and it's worn off, right?
Mhm.
Um, how does that how does that create a continuing effect? Like, is that because I mean, this is one of those things where, you can go, you can have an experience, you can get high for a little bit, you come back, you go back to normal life. But in this case, it doesn't. You have that one experience that is an acute experience. And once you have had that experience, it does have a longevity effect. It does have a downstream sort of continuing impact. And what is that like, just from an experiential point of view?
A little bit mind blowing because I can only quote my patients. One said, "My self loathing voice went away. Hasn't come back yet."
Uh-huh.
One said, "I wish everybody could do this. This is amazing. I wish everybody could feel what this feels like." Because it was a feeling of self-compassion and gratitude and just all those good feelings that we know that we are capable of.
Humility, right?
Humility, surrender, there's all of those aspects of being human that kind of, we turn up in our full spectrum selves. And once you've seen yourself in a full spectrum self or felt it, there's no going back. You've opened Pandora's box um, of transformation, and the transformative changes that can occur can be subtle. They can be incremental. They can kind of stack on each other. It can change relationships, like that
Mhm.
mother and daughter, right? Like years of not being able to bring forth the language, suddenly the barriers drop to that kind of communication. Um, in some ways, what happens is we go into a more vulnerable state. We go into a more pliable state. And one of the things that they've said is on the ocean, um, the kind of temperament indicators, openness, agreeability, and all of that, like extrovertedness. There's like an ocean scale. What they've seen is that trait openness increases after
Mm.
psychedelics, which is why they also put you in a more vulnerable state. So we actually tell people, don't make any big financial decisions, don't make any big life decisions. Make sure you have a supportive network around you to make sure that whatever destabilization is coming from this transformative experience is not negative, is mitigated
Yeah.
as much as possible. Because we see that all the time. There's ego inflation. There's this like, oh, I'm gonna, because there's this hope and beauty and kind of like full spectrum access to who we are that shows up. And
Mm.
that can feel very empowering. That can feel very grounding. That can feel, give people a sense of hope and resilience. And going through a near death experience and making it through the other side and kind of getting used to that dissolution of ego is
Yeah.
such a great, I think, path to step into. I mean, this is what the meditators are doing, right? And I think I saw a question over here is like, what is the kind of correlation between meditators' brains and brains on psychedelics? And there is a lot of overlap. Long-term meditators and people whose brains are on psychedelics, they do have a lot of overlap in the parts that are connecting up. And,
Mhm.
and so we know that these medicines are unlocking a capability we all have, which is such a radical idea, right? People come in the door going, please fix me. And they leave going, oh, I have the ability to help myself. I just needed the space to connect with that ability. I just needed those connections to be made to my realization of that ability being present. So some people will say, oh, I get a little gap between my trigger and response. Oh, I actually feel like I can wake up in the morning and take a shower and actually go out. And that leads to me having a better day. So
Mhm.
increased quality of life, decreased rumination, better relational dynamics, having empathy.
So again, and I'm sorry I missed this, but if you had there's a question about how many sessions does it usually take? Because a lot of times people wear antidepressants for life, and
Yeah.
I think it was a comedian who went out and he asked, he's like, how many of you are on antidepressants? And a whole bunch of people raised their hands, like, and how many of you are depressed? And they all raised their hands again, like, well, what's the point? But so
Apparently.
yeah, so they stay on these SSRIs for a very, very long time. But with so with ketamine, how many sessions do you really need to go through to have an effect that is now um, sort of now established?
Right. How do you get to a new baseline? People
Yeah,
always ask this question because we want to know when this ends, right? This is not ketamine for life.
yeah.
Um,
How many doses or how many sessions on
although,
average?
yeah, I kind of framed all of this in the earlier stuff I said because it really depends. It really
Mhm.
depends. The industry standard is to try six sessions. And generally with kind of like the average person with the average kind of, diagnosis, 6 sessions gets them to a new baseline, uh,
Oh,
a different level of experience, with lower kind of lower scores on their psychometric scales for depression, anxiety, and PTSD. So about 6 sessions spread over 4 to 6 weeks. Although we've had situations where somebody has booked out the full six, and by 4 they were like, I think I'm in a really good place. I think I want a little break, between now and let me see how it goes. And so that's what we encourage is, we don't know how resilient somebody is. We don't know what strengths they have, what abilities they uncover with each journey. Some people have amazing kind of transformative experiences where they're like, this just feels like a new baseline.
yeah.
And even though I go up and down still, I still have really deep depressions, I'm able to bounce back to my baseline with a little bit more resilience.
Well, the teach a man to fish thing, right? Like, I mean, that
Yeah.
except this time you're giving him a fishing pole and a whole apparatus, right? You give him entirely new tools to. So,
Helping on fishing tools.
yeah, yeah. They're not. The idea is that it's not just that. you go through things. I mean, these stressors aren't going to change. The world's not going to change. Everything that the world throws at you isn't going to change. And your ability to feel it isn't going to change, but your ability to deal with it, the tools to approach it differently, to look at it differently, to really exploit some of the new neuronal connections that have formed in your brain, that's where it kind of that's where the long-term efficacy comes from, it seems. But so speaking of this, just on the studies, and I wanted to also talk about, be fair and talk about some of the drugs. So we're coming on to an hour. Do you have a little bit more time, please?
Yes. Yes.
Thank you very much. Yeah, it's very nice. I'll go this. So Cam Dokus is asking, he's like, how is the study quality for the use of, say, ketamine on depression? I keep hearing for and against, good or poor quality. And then, yeah, so, and then there's another related question. But first of all, this with this, what's a study quality like? What's the research like? Like we said, this thing has been around for a very, very long time. It's been extensively studied, right, under supervision. There was a case. There have been cases that have scared people, like Matthew Perry from the actor from Friends, like Canadian as well, fellow Canadian. Where I am here in Canada, he died recently, and of ketamine. He apparently had high levels of ketamine in his blood. So stories like that, how would you respond to people who bring that up and talk about how this can be very, very dangerous?
Yeah. So thank you, Cam, for that question. When it comes to ketamine, it's been used as an antidepressant in this model starting from the 1990s. There are researchers in both Russia and Iran who actually started work on this. So we've had studies from that time onwards. The recent studies have shown that, we're comparing the study arms of ketamine versus, any kind of SSRI, just ketamine on its own, ketamine with the SSRI. There's all of these different arms, right? And we're looking at what's the efficacy of it. And we're seeing 70% remission rates in treatment-resistant depression. That is the industry standard right now, is, clinics like ours who are providing the ketamine in this model, this interpersonal, set and setting psychedelic model, are seeing, 3 out of 4 people who otherwise were treatment resistant are able to achieve remission or a decrease in symptoms. And these studies are,
there's scales by which you measure that, right?
There's scales by which you measure that. So the psychometric scales that are used, pre and post, we do that as well. We track them. A lot of these studies, ketamine, when it first approached FDA approval, and this might be a good place to just mention FDA approval. When it was first applying for FDA approval, we didn't actually know that it has this dissociative effect that is now a therapeutic. We didn't know the therapeutic value of this dissociative effect. So when it was first studied for the FDA, large scale randomized trial studies, the dissociative effect was deemed a side effect. So a lot of the studies suffer from this notion. If you look at all the different studies that have been done, some are actually treating this therapeutic effect as a side effect. Because of the way it's already been framed around ketamine. Now, because ketamine is such an old drug, it's gone generic. And so there's absolutely no reason for pharma companies to invest money to redo these large-scale trials for the antidepressant effect. It makes absolutely no sense because it's dirt cheap. So what they did was they took racemic ketamine, which is ketamine, which has 2 isomers, the R and the S. They took out the S isomer, isolated it, created a new drug called Spravato, which is what the nasal spray is, and did some of the studies on that. And even though it's only 1 isomer, on some studies, it's been shown to either have equal efficacy or better efficacy than SSRIs. Even just the nasal spray doesn't do the psychedelic effect as much. It just gets the antidepressant effect. There's multiple channels on which ketamine is working. And so the antidepressant effect, what we're finding out is it's being created by the metabolites of ketamine, and they can linger for 18 to 24 hours out. So there's an actual molecular basis for the antidepressant effect that we found.
What is the so there seems to be this trepidation around the psychedelic part of it. So they're
Yes.
like, okay, can we isolate that from the high? What? But they're what is the concern about the psychedelic effect? I mean, so I know that people have bad trips, right? And okay, let me just actually bring in some more questions here that are related. So Ilmana Qureshi is asking, are there any adverse effects of ketamine psychedelic therapy? How does resistant depression as part of bipolar disorder respond to it? And will it precipitate the manic phase? So that's one question that's we can bookmark. And then I'm going to bring this in addition to that from Alison Feiner. She's saying, what effect does ketamine treatment have on the dopaminergic system? Is it recommended for those with both treatment-resistant depression and ADHD? So just first of all, the adverse effects, and then we can talk about it in bipolar and in ADHD.
Yeah.
So
the
psychedelic part was that you said is thought as a side effect.
So yeah, I mean the other piece too before I jumped into this is that the FDA, and when you say, oh, is it FDA approved for a medication or is it off label or on label, right? That's what it means. Is FDA approval means it's on label as an indication, and when it's used outside of what was initially FDA approved, it's called off label. Let me remind everybody in our audience that most medications that are used in pediatrics are used off-label because we don't actually include pediatric patients in these large-scale pharmaceutical trials. And so when we talk about off and on label, it's really about the FDA approval process. A lot of medications are used off label for a lot of indications, So for example, like erythromycin is an antibiotic, right? But it's also used as a promotility agent in neonates. Right. So it's right. So when people say is it off label and there's like a stigma attached to it, it's really hooking onto the societal stigma that exists around psychedelics. And for that, we can go back to, Richard Nixon. We can go back to the time when, Timothy Leary was out here protesting the Vietnam War. There was like a lot of civil unrest. And he was encouraging people to, what was it? Tune in, turn out, and drop out, or something like that. He kind of really personified the face of a generation completely disengaging from the war machine, disengaging from the, and actually protesting, actually just deciding that we're not going to be part of this governmental kind of, warmongering. And that was scary. That was scary. If there's a drug out there that's going to make people peaceful, governments don't want this, and so this is part of the, they showed videos of people's brains, like of eggs frying on pans, showing this is your brain on LSD, right?
Yeah.
So you see those things as a child. The generation that is now, physicians and in administrative positions and in leadership, they grew up. We all grew up with this idea. I had not done a psychedelic until just recently, barring college, experiences, very, very mild college experiences. But there is a kind of suspicion of this idea of psychedelic, and we could go into real depths about where that comes from. And really that's a cultural stigma that we're dealing with. So when we talk about, is there side effects for bipolar, or, is it going to cause psychosis? The cautions right now are that if somebody is, for example, in their upcycle of their bipolar disorder, that they not do a psychedelic, okay? Because it can drive them into a manic episode. But if they're in the depressive phase of their bipolar, it can be done safely. And so practitioners who are, providing ketamine therapy, that's one of the parts that we talk about in the screening process is, are there any risks? Is there a risk of psychosis? If somebody's actively psychotic, no, do not give them this, and there's also this aspect of harm reduction. Okay. So I can bring in this idea that, not idea, but this work that I did with Zendo Project, which, and there's another another resource called Fireside Chat, which provides 24/7, harm reduction services. And what they're seeing is that in situations where people are undergoing difficult psychedelic trips, for example, the best thing to do is to keep them safe and to accompany them. Don't abandon them. Don't restrain them. Don't chemically or physically restrain them. Stick by their side and just hold space with them, talk to them, ask them what they're going through. And as the medicine is coming out of them, they'll have a gentler landing. So when we're talking about this kind of frightening, I'm going to get stuck in a really bad trip, those are, LSD is, I think, the most likely to give people bad trips because it's so long. It's like a 13-hour ride. And if you are out in traffic, if you're out on a night and you're drinking and you're mixing substances and you don't have good set and setting, of course, it's going to turn into a bad trip, So
you described, like you said, that bad trips, when you wrote, you said that they're badly held containers. What do you mean by that?
What's a container? It's like the ball. So it's a really fascinating. I'm learning all of this lingo, right? It's set and setting. The mindset that you go into, the setting that you are surrounded by, the trust that you have in your practitioner, the container, meaning how secure are you feeling? Are there going to be interruptions? The worst thing that we can do when somebody's in a psychedelic journey is interrupt them. Or, is there going to be a fire truck going by and are they going to hear it? Right. And that's going to spin them out into a completely different space. Right. Because in psychedelic journeys, we have greater sensitivity to light and sound, greater suggestibility. And so protecting the container, meaning creating a boundary, so when you enter into the space, we're not using our phones, our phones are turned off. We kind of create a nice, clear, kind of safe area for people to be able to express whatever they need to without feeling like they're going to be shut down or they're going to need to self-censor in any way. So the container is really just about safety. It's a way of talking to each other about, when you enter into the container, what happens in the container, and then when you leave the container, like really protecting the space in between and creating some sort of ritual entry and exit points, because
like
it's also
the buffer between the person undergoing the experience and the
it's a psychological it's a psychological kind of method to trigger a safety response, right? Because we step into the same thing. It's a ritual. It's taking advantage of the thing that if we do the same thing, just like prayer, right? If you pray in the same way every single time, you enter into that space of prayer every single time, your mind and your body get into that, neurobiology, that neuro state really quickly because you've already it's Pavlovian. So in the same way, if you create a container, it becomes a Pavlovian response for people to be able to sink in sufficiently
and get into that mind state. So, and then the effect on the dopaminergic system and any utility. And you mentioned ADHD. So, is it right now any experience with this in treatment resistant or in ADHD? Not treatment resistant. Talk about it.
Well, this is where I think I would even defer to a psychiatrist, because everybody's, diagnosis of ADHD would be, how does it show up? ADHD has become such a kind of like diverse disease, right? There are so many different expressions of it. I am familiar more with the kind of, when patients come to me with ADHD and treatment-resistant depression, if they're on medications that are stimulant medications, for example, I would caution against using the stimulant medication on the same day as the ketamine experience, because both of them can be additive and it can upregulate their kind of, physiology, and that can feel anxiety inducing. So in that way, I would actually say that, you want to skip your medications for ADHD on the day that you have your ketamine experience. How that's working on the dopaminergic level, I would not even hazard a guess. but there is some, ketamine has, just to kind of frame it, ketamine has effects on a multiplicity of receptors, including serotonin, including dopamine, and some opioid as well. So,
Mm.
yeah, so there's an anti-inflammatory effect happening. So there's multiple layers of neurotransmitters and systems that are being brought online. So that's how I would deal with ADHD and treatment-resistant depression if I were to go ahead and do ketamine therapy with somebody.
One more thing, and I think you probably addressed this, but in terms of meditation. But what happens if you administer ketamine when a person has entered a hypnotic state, or does it affect learning latency? Is it increased, decreased, or unchanged?
That's a great
Anything
question.
you know about that, or?
That's a great question. So what I know about this is before you enter a psychedelic space, like with ketamine, if you bring up the experience or the memory or the challenge that you're dealing with,
Mhm.
what happens in the psychedelic space is, yeah, we are able to, I don't know if it's an increase or a decrease, but we're able to rewrite the kind of association that we have with that memory. So it just changes in its character. It changes in its kind of, we learn to see that same experience from a different perspective.
Right.
Yeah. Mhm.
Oh, okay. Okay. So I wanted to just shift because I know that, there's so much to talk about, but moving to, the difference between ketamine and then the psychedelic treatments like psilocybin and MDMA. What is the difference between them, just in terms of how they act? I guess in terms of their mechanism of action, and also their therapeutic effects from an experiential
Yeah.
perspective.
Yeah, it's very fascinating because a lot of what we're learning or know about this is coming from the underground, right?
Mhm.
So there have been people who've been using these medications, these molecules for decades. Psilocybin, we know about it from the Mazatec curandera down in Mexico,
Mhm.
who was discovered, Maria Sabina, who was discovered in the 50s. And that's how the Western world started to learn about psilocybin. However, when you look at the history of human civilization, there have been psilocybin-like compounds for centuries. The Eleusinian mysteries. There's just this, there's this kind of moment where we realize, like, oh, this is our heritage in some way. Psilocybin grows on dung heaps everywhere except at Antarctica. So
Mhm.
there's something very interesting about a molecule that is created by a fungus that connects us with our deepest selves, with Earth, with the universe. It just feels like this amazing gift, right, from
Mhm.
the Earth. The other interesting thing is LSD, the molecule, and its kind of discovery or invention by Albert Hofmann in Switzerland, happens in the same year that we actually, detonate our first nuclear weapon, nuclear bomb, right?
Yeah.
So it's kind of like moment in Oppenheimer where he says, "I am become death, the destroyer of worlds." And this so when you talk about these different molecules, I really like to bring up this history, that it's nothing new. It's really something very ancient, and I think people feel that when they're on these different molecules.
Mhm.
Um, MDMA is known as an empathogen. It's not strictly a psychedelic, so it causes open-heartedness. So when these underground practitioners have been using it, sometimes they'll actually combine different molecules together in a very kind of curated fashion. And so you'll hear about, underground practitioners going ahead and starting with MDMA because it's a heart opener. It decreases the barriers to relational work. And so if somebody's been really locked down, it can really make them open up about everything. And then they go on that mushroom journey. And so everything, they're in an open state and they go on into this kind of non-ordinary state of consciousness. So it's just super powered up. And then sometimes they'll end with a ketamine journey to kind of bring it all back home and into a therapeutic space. I mean, it's kind of a little bit of a wild.
A lot of EDM and Tulum, right? No, so I'm just joking, but when you say underground practitioner, do you mean is that drug dealers?
No, we're talking about a very legitimate, kind of widely, let's kind of scroll back to the notion that this is relational medicine, that this medicine has been used in different. So if you look at every culture, they have some form of this. Usually it would be held by a shaman, and in certain traditions, it would be the shaman ingesting the psychedelic, not the person who was approaching the shaman for healing. So there's this great book by Joe Tafur, who's a family medicine MD, called The Fellowship of the River. And he talks about going into, Colombia, where he's from, and, really learning with the Shipibo tribes, who hold this medicine, what it's like to cure somebody. And he describes this passage, which is just fascinating. While he's in the medicine and the person is in the medicine, he can almost visualize that person's body as if they're in a CT scanner. So there's this kind of interactivity that is happening between the guide and the person who's journeying. That is part of what underground work involves. So what we've been talking about really has been called the medical model. There's an expanded model that underground practitioners, and the best description I can recommend of this is a book by Rachel Harris called Swimming in the Sacred, where she has interviewed I think a dozen or less female, mostly practitioners, underground practitioners, who have held this medicine, and held it during times where it's very perilous, very dangerous to do this work, and yet they continue to do this. And so when you talk about what they're doing in the trials, they're actually emulating what the underground practitioners were already doing. So we're just standing on the, this is where the psychedelic kind of renaissance is really not struggling with, but seeing this kind of dichotomy of like, oh yeah, now that we can make money out of it and we want to legalize it, but how about when it was being done anyway to heal people, and why were we criminalizing it? It's just this really interesting time where we're kind of in this schizoid space with how to look at these things, and so really want to bring it to this is nothing new. This is just an old old technology that we're rediscovering and like thinking that we're really smart. But it's been there the whole time.
But so there's only I think there's three more things that I wanted to ask about. First of all, just more on the side effects, to give a what specifically happened to Matthew Perry. So Christine Michelle is saying it can have a negative effect on some. There are, always possible side effects with any treatment. And I saw this one comment here from Skateros is saying that, why is this in my recommended when I'm clean off ketamine for 2 effing years? So this is a guy who was on ketamine. He got clean, and now, we're here talking about how ketamine's the ketamine's amazing. So what is what is the downside, the Matthew Perry side?
I would say ketamine's not amazing. We are amazing. Ketamine just uncovers how amazing we are.
Oh, I love that, Simi. You're very good.
It's not about the molecule, it's about the human being. This is a humanistic medicine. This is relational medicine. It's, that's why I'm drawn to it, because I was kind of looking at these skills, using these skills even before I started to use the molecule. In addition, it just supercharged what we were doing. So good questions, all of, Skateros. I think you are amongst a lot of people who are feeling this right now, because to be, ostracized for something that now is becoming legal is something that a lot of people are going through, right? People who have been arrested, been in jail, basically labeled, basically put outside of, shamed in some way, are now finding when they open up their feed that, oh, you're trying to sell me ketamine now, like this is legal now, just it's we live in a very strange world. I agree with you. I'm sorry about that, but that's the algorithm. And it is, I hate to kind of always be a positive spinner, but you know me as a Pollyanna, so unfortunately that's like my baseline. This is not me talking about ketamine. This is literally me talking about anything I love, right? Or anything that I find fascinating and enjoyable. I mean, I've been, I have to admit that the length of my experience and my knowledge within psychedelics is probably within, since the pandemic. Um, and it's been growing and evolving as we talk about. So I have not been part of the psychedelic world for a very, very long time. Yes, there are negative effects. The negative effects come from that place of vulnerability that we put people in. So you might be hearing about some of the things happening at the ayahuasca retreats, the sexual assaults and the taking advantage of people. I mean, Charles Manson was on LSD when he did what he did, right? So there are ways to use these molecules for mind control. MK Ultra, CIA was trying this. LSD has been used during interrogations by Navy SEALs. I mean, this is bringing us back to the idea of what's a medicine and what's a drug when it's the exact same molecule, right? What you do with it, what set and setting you put around it, what your intentionality is, what your understanding of the risks involved. Like if somebody is, for example, when you're talking about the side effects, if somebody is so destabilized that they can no longer function at work or are having kind of a disconnect from their regular world, that they're staying in that dissociative state, that can happen, right? So if we fail to take care of the landing, and this is something that we can segue into talking about because the integration part is really, really important. It cannot be emphasized anymore. It's integration means, yes, I had this big experience. Now, what does it mean? How do I take what I learned, what I experienced into my life in a way that integrates well, that integrates into my neurobiology? So some of the things that we actually recommend people do after ketamine journeys or psychedelic experiences is go out in nature. Go into a space where you can, have a digital detox, where you can be in a safe and warm environment and being out in nature. Nature in and of itself has healing properties. And so psychedelics kind of open us up to that kind of healing, which is fascinating.
Yeah. So, and then what about the actual adverse events, like the pharmacological?
So pharmacologically, with
can you
ketamine,
overdose and acutely, that kind of thing?
Well, going back to Matthew Perry, so he's a great example. I'm so sorry because Matthew Perry was and is, I think, a part of a lot of our young adulthood. And when that happened to him, we all felt it very, very deeply because it didn't need to be that way. It really didn't. And so when something like that happens, just from a moment of not paying attention, I think it really highlights for us that this is not to be messed around with. There are a lot of drug interactions. So one of the things that I do and we all do is make sure that all the drugs that our patients are taking in addition are not going to enhance the effect of ketamine, right? And there are medications that do that. And because it's acting on that metabolic level and so being aware of the risks. The second risk is hypertension. So if somebody already starts out at a high level for blood pressure, we would give them blood pressure lowering medications and make sure they had a normal blood pressure before they started, because I wouldn't want to send somebody into a hypertensive crisis. So the third thing is the airway. So if somebody has problems with snoring or a really narrowed airway, they may be at risk for respiratory compromise. It happens at the higher doses, but with somebody who, with that relaxation that comes, and they have sleep apnea, they may go into a state of not breathing enough.
Mm.
So having somebody to watch you constantly is the absolute standard in ketamine therapy. So this whole idea of leaving somebody in the room while they're on ketamine, I think does patients a disservice. On both those levels, the safety aspect, psychologically as well as physiologically, no matter what your monitor is telling you. I
Mm.
think these are things that may appear even at lower doses. So it's just because it's a low dose doesn't mean we're not going to have um, an adverse outcome. And so, in a clinic like ours, we have oxygen, we have, a full crash cart. And yet a lot of our, ketamine clinic provider colleagues will say, yes, it's good to have, but you're never going to need it. But it's good to
Yeah.
have for that time you do. And so that's the mindset that we go into this with, which is harm reduction, which is making sure that we've thought of every avenue in which this could go wrong. I do a real titration during the journey. Different people do it differently. And so I found that that's a really helpful method, because you're right. Somebody's sweet spot might be 0.5 mg per kg, and somebody's sweet spot might be 1.5 mg per kg. That's a
Yeah.
3 difference.
Yeah.
And so how do you adjust for it, but also make sure that you're not, playing fast and loose with the dose, right? So
Mm.
that's a whole kind of strategy there that we deal with in the clinical space.
Okay. Yeah, that sounds good. I had a question about sort of microdosing, right?
Mhm.
And so just for everybody, can you just explain what, because we hear about that all the time now. So
Yeah.
can you just explain what microdosing is and how that's utilized and your experience with it in terms of how that fits into ketamine therapy or psychedelic therapy.
Yeah, I mean, this is probably the thing that I'm least equipped to, or qualified to talk about, because microdosing in and of itself, the kind of the biggest data set that we have that James Fadiman quotes is, I think, about in the thousands, who have microdosed, and the benefits that they've achieved. And microdosing is basically where you take such a small dose of a psychedelic that it is subperceptual, meaning you should not be able to feel its effects.
Mhm.
So it's like it would be something that's measured out into a capsule that you would take, maybe early in the day, and people report feelings of, oh, I can focus a little bit better, I have better concentration, or I just feel better. There's subtle effects that are happening in all of that, in the connectedness, and all of that, which is just really fascinating, and kind of a place where, as a physician, as a scientist, as a science person, not a scientist, but I would say that's interesting. What's happening here? What's the context within which this is happening? That people are taking this, but I do know that one of the side effects of microdosing that I always caution about is there is and psilocybin specifically is acting on the 5-HT2A receptors that are scattered everywhere, and different concentrations, but they're
Where's
really
there? Yeah.
Mhm. They're
Yeah.
really concentrated on the leaflets of the heart valves. And so one of the problems that we may see in the future with all of this microdosing is unrecognized heart valve damage from constant use of microdosing. And we don't know that number yet. We don't know that.
That's microdosing specifically
Ivan.
with psilocybin. Okay,
Mhm.
but not necessarily with ketamine, because I think that's one of the things I was when I first read about
Mhm.
the Matthew Perry thing. The reason I've been asking about it so much is because I haven't really, like, with ketamine in terms of acute effects. I have seen things like dizziness, confusion, nausea, some or even long term effects, withdrawal, developing tolerance and withdrawal symptoms and things like that. But that was actually something that surprised me. It's not something that I.
So here's the thing. So a patient of mine did ask me this question because they actually didn't want to do ketamine in the psychedelic model.
Mhm.
Because it's just too much. There's a lot of material. Yes, it's enjoyable, but it doesn't fit in with the rest of my life. I can't be doing this because it's a whole day taken out, right? I mean,
you got to commit to it. It's a commitment. Yeah.
For some people, this is just not going to work. So there's a practitioner who for years has done this and actually has a pretty robust data set, but hasn't published it, of using ketamine in small doses. So an oral solution of maybe 10 to maybe up to 50, 60 milligrams once or twice a day. And that is enough to give them the antidepressant effect without the dissociative effect.
Yeah.
And so there are people, and they call that microdosing, but I'm loath to call anything a microdose because I feel like that just gives us a psychological out to say, I'm really not using this drug, but I am. You know what I mean? Like, it's like, are you using it or not? Like, it's dosing. You're just dosing it at a smaller dose with a very specific indication, which is the antidepressant effect, and it's having good results. That's the bottom line, is that it's having good results. And so with psilocybin microdosing, that's what we're seeing is people having really, like what you've seen, people mentioning in the comments, is feeling like it saved their life. And that's a very interesting place to be, is, when we really come to this, this work, people are so grateful. People are so grateful that we do this. And it's, it's of course it feels good, but even from that, we separate ourselves and say, well, it's not us. It's just that we are able to provide this service. And, it's just that it does actually save their lives, which is a really kind of incontrovertible, kind of evidence that something about this is working. And we may not know exactly how, but at least we have some guidelines, we have some cookbooks, we have some, parameters, we have some conditions which we know will lead to better outcomes versus not. And so, yes, I think for everybody who said this, what are the negative effects? The negative effects is, maybe going into it having expectations that are unrealistic. I mean, that's one thing that the media is doing. And I think Elon Musk's, video was sent to me by a half a dozen people, including yourself, because all of a sudden, because he's talking about it and he's taking it, it's now a topic that millions of people who, own shares in his companies are worried. They're like, wait a second, he's what? He's one of those.
Yeah. It happened when he smoked weed on Rogan. Same thing. Everybody freaked out as investors. Are like, well, what's it going to do? So that is kind of it. And then I think he said that, people should, and investors should be
thankful,
more confident. Yeah. They should be grateful that I'm taking this stuff. So they should be encouraged by it. But anyway, that's a whole other content. I mean, the world's crazy right now on social media. I wanted to address my friend Mookie Spitz, who comes on with me quite a bit, and he's actually coming on next week as well, so that's gonna be fun. But he had put a question earlier. I'm going to just read it out, and I think we talked about, you've already addressed this, but I just want to read it out for listeners. He said he worked on a pharma ketamine brand. He's a medical strategist. So pharma ketamine brand, actually the biggest hurdle to adoption seemed administration. Nursing centers were set up to supervise patients undergoing treatment, which proved to be a hassle. From what I could tell, another impediment was the company's approach to treatment, which failed to create an experience, instead focusing on simply getting the chemical up a patient's nose and the patient eventually out the door. Can you talk about the importance of holistic care and how treatment using ketamine and other psychedelics should go beyond mere dosing? And I think, we did discuss that quite a bit. I mean, I would just say that, if you're doing this and that you don't have a team with you, you're not supervised, you're not being watched, just don't do it. And that's, I think, it has to be done right now with in a safe and a comfortable environment. Like you said, you were talking about the container, right? A bad trip or is just a badly held container, and you could hear a fire truck outside, and it can completely throw you off, and it can become dangerous. It can be a problem.
Yeah.
So
Here's an additional answer to Mookie's question that we're learning from the MDMA trials, which is really interesting, is this, idea of a corrective experience, a corrective emotional experience. When you get into the container and you can open up your Pandora's box of emotional material, right? Let's say you had developmental trauma with parental figures or whatever. There is a part of the treatment that is occurring along with the therapist, meaning there's transference and countertransference occurring, just like in any kind of, therapeutic interchange, right? Like when you're talking to your therapist, you're going deep into process, you're projecting, oh, you're a female of a certain age, you remind me of my mother, there are emotions that I'm feeling towards you, that I feel towards my mother, and that's coming out. Okay.
yeah,
And there can be a lot of shame and guilt in feeling those emotions. And here's where the therapist can create that corrective experience, or provide that corrective experience, by just being an empathetic, open, understanding presence. It's
Mhm.
really about presence. And so when that corrective experience happens in, in the context of a journey, whether before, during, or after, it is so healing for people, because that's really the basis of this. It's not like you're sitting in a room by yourself, safe as can be, tripping on this and coming out a new person. It's that you've had now this experience of disconnection to connection, right? Disconnecting in order to connect with yourself, with others, and healing through that connection, right? Because how is it we feel better when we tell somebody about our problems? Like
Mhm.
when a patient comes in sometimes for the first time, and I have my hour and a half long intervention with them, like, interaction with them, where I ask them all the questions, we go really deep, we excavate everything. They come
Mhm.
out going, "Oh my gosh, I feel like that was a psychedelic experience. Like, I just felt like I went a long way with you, and I was able to do that because you gave me that sense of safety." They feel a sense of relief.
Mhm.
And so even before I give you the molecule, you are already stepping into this container of trust and understanding. And that your healing has already started. Somebody here is holding out hope for you to heal, and this space is being created for you to heal. And when that, transference, countertransference, when that really powerful emotional experience is happening, you can trust that this person will treat you back with this level of respect. And in your own process, we won't judge you. And there are times when you feel that judgment come up, right? Because we're all human. You feel
Mhm.
that up, and you want to kind of like, and that comes up, and the training is to be aware of it, to understand that that's my reaction, that doesn't belong here, to keep myself out of it. So if you could even just imagine, like what Mookie is describing in those clinics, they were not doing any of that. They were
Yeah.
just putting you into a vulnerable state while changing nothing about the character of any of the relationships around you, And so they were putting you in a sense of disconnect while you wanted to connect, right?
Mhm.
Sometimes we can actually re-traumatize by not being there for people when they're finally open, right? Like somebody has struggled with mental health issues. They've lost trust in therapists. They've lost trust in medications. Here they are coming to this life-saving treatment they've heard is going to work amazingly. And yet again, it's isolation, separation, disconnection. Oh, this is your problem. Oh, work through it on your own. Whereas the healing aspect, and this is why group therapy with psychedelics, I think, is going to start to become the model, because it is so expensive to do one-to-one. And they're investigating that, and I think we're going to find that there's a lot of benefits that outweigh the risks. And so group therapy, group process is really, really critical. For example, if let's say we do, and there's a study out there showing group work with healthcare workers with post-pandemic burnout. And just being in a space where people understand what you went through and can really, you know, be with you in processing your material is so healing. Like sometimes what we'll say is somebody else has the medicine that you need. Somebody
Mm.
else has insight from their journey that they're going to speak out. And that's going to be the thing that makes you just open up or feel that you were seen or heard, or your experience wasn't isolating, that there was somebody else there. The other
Yeah.
fascinating thing is the mind body connection and music. In the MDMA studies, they showed that sometimes a tension would show up in a muscle somewhere, and they pressed on the muscle, and it led to this barrage of emotional content coming out. So, this idea of the trauma, the body keeps the score, and embodied trauma is really connecting with this psychedelic work. And music
Mhm.
is a fascinating space because you not only become synesthetic to music, the music actually carries you through the journey.
Yeah.
So music is hugely important. So if you go on Spotify, there are a billion ketamine playlists of all of
I think
all
it's gonna be a playlist. Yeah.
and transcendental music that's happy, music that's sad, music that really brings emotional tones together, um, is really useful because it'll shift people into emotional states.
Yeah. So one more thing. We have a question here about mindfulness, and then I promise I will let you go. Um, so great discussion. I'm wondering about how self-referential areas of the brain on the medial wall respond to ketamine. You mentioned your ability to go through vicious ruminative cycles gets short-circuited. How does that compare to effects of mindfulness? Have there been any head-to-head studies? So, that's kind of interesting. Has there been a parallels with mindfulness? Or
Excellent question. Thank you, Dr. Z. It is fascinating. There are some signals in the data, and at USC, a colleague of mine, Rael Khan, who is the head of the Center of Mindfulness, actually just got approved to conduct a trial with psilocybin with and without mindfulness training. And
Mm,
so the other signal that we talk about is when we do fMRI scans of brains of long-term meditators and brains of people on psychedelics like psilocybin, there are a lot of overlaps. So the way I kind of talk about it is meditation creates those capacities for stepping out of that self-referential space. Absolutely. Because in a meditation, you're practicing how to let go, right? One of the kinds of meditation is you're practicing how to let go. And and that's actually one of the things we do as people are sinking into their ketamine journey is we do a breath work and body scan where we just prime the brain for that process of letting go. In that brain body space, so it's
mm,
kind of like stepping your toe into becoming a long-term meditator for an hour, and doing it consistently without a lot of concentration required or training required. So yeah, I'm fascinated to see. What I have noticed anecdotally is that people who are long-term meditators are very, very sensitive to psychedelics. It
mm.
doesn't take them very much to go very deep, and they're able to kind of process through somatic work and really engage in a deep process. And that brings me to the other piece that I always talk about is what's a person's worldview. If they are a religious or atheist or whatever it is, or agnostic, it's important to know what that person's worldview is and how they would experience or describe, be able to describe what that unitive, connected to the universe feeling. How do you reconcile to that once you've had it, right?
Mhm.
How do you bring it back here and talk about it and say, hey, you know what? I kind of felt like I was one with the universe. That's not something you can just randomly talk about to a stranger. There's no worldview in which we can easily talk about this. So it's really important to kind of, ask people, what is your worldview? And warn them that there will be shifts in the worldview. And this is where the whole cult piece comes in. It's very easy to start a cult with psychedelics.
Yeah, yeah. No, I
Um,
understand. There is a lot of yeah, it is confusing because I think that there's a very, very legitimate area, and we've talked about that a lot, but there is that whole other sort of cultish, community cultish community element to it. That
It's already happening. I mean, it's
well,
already happening in the whole kind of like startup culture of
yeah,
psychedelics. You'll see it.
so it's a little difficult to, and people.
And I'll address Hussein Danani's comment because it's not actually off topic. It's very much on topic.
Okay, so this one, let me just read it out for the people who are listening and not watching. He's saying a little off topic at hand, but I would love to hear your strategies for developing the insight to keep one's judgment and biases in check. This is, so that's kind of what we're getting at.
Big question, and one that, all the way from training in ethics. There's a great book by Kylea Taylor called The Ethics of Caring, where she really is a psychedelic practitioner who practiced with the group at Esalen near Big Sur, the kind of where a lot of the holotropic breath work, work was done and all of that. And she came to understand that the ethics in psychedelics requires us to, one, do our own work, meaning be on our own process always, whether it's dealing with our own trauma, dealing with triggers as they come up, having a community of our own practitioners who can call us out on our biases and our bullshit, right? So I have my friends who I can just call and say, hey, this is happening, help me out, or I'm feeling really like this. And really, this is not easy. Most psychedelic practitioners will say that this work puts you as the practitioner through the ringer in ways that other work doesn't. So this is a contact sport for a lot of practitioners. This is really, it's not that you're taking your work home with you, but there are pitfalls there, right? It could be so easy to enter into a mindset of grandiosity. Right. Oh, wow. I'm helping so many people out, and this is all about me. It can again start to feed the ego. Right. So I think it's really important to have not just psychological, kind of knowledge and expertise, but also to have your community around you and do your own work and be willing to say you're wrong. And I think, humility, it goes back to that. Is like, if we can conduct ourselves, hold my beer, come to the ICU.
Huh?
I don't know what to say.
Oh, okay. You're laughing at this, yeah. Hussein's not. So Hussein is also a friend of ours. He's also a physician. He's saying, "Hold my beer, come to the ICU." Okay, excellent.
So it's I've been in the ICU in pediatrics. Ketamine. The most, I think, memorable case for me was of a child with intractable seizures who was in a ketamine coma for 3 weeks, and the neuroplasticity, the BDNF, all of that worked to resolve her seizures for a number of years before they returned, which was fascinating.
Yeah.
Work inherently feeds our narcissism. Yes,
our work inherently feeds our narcissism. That's great. Okay, so yeah, we could go on with this, and I don't know. There's so many aspects of this. We've talked a lot about the actual treatments and so on, and well, I guess we've covered many things, and maybe we didn't get as much into the whole idea of the future of mental health treatment and sort of the broader discussion around that. Maybe hopefully you can come back at some point and we can talk about it. And maybe since it seems like a lot of people have a lot of questions, maybe we can just do like a little question answer thing. It'd be great if you could answer questions about it. But
future of mental health treatment. I'm doing this because the more we talk about it, the more we normalize it. All my colleagues who are already, in hospitals where ketamine is available freely, not freely, but ketamine is available easily, are unaware of this, and as physicians, just being aware that when you are administering ketamine to a patient in the hospital, it is important to pay attention to set and setting. Just if you take that away from this as a physician, that's enough. Just because I felt really bad when I found out after years and years of administering ketamine, having no knowledge of its psychedelic experience. It was something that really was sobering for me. So humbling for sure.
Yeah, well, fascinating area. It's super, super interesting. I'm just I'm more and more curious about this every day. So I think, and we're also like, I work in sort of healthcare, pharma, communications, and we're seeing there's a lot of pharma companies that are actually coming up. We're seeing a lot of the stuff really coming up on the horizon. So I think it's going to be a really transformative coming few years through the
Yeah.
conversation, this and the impending approval. So, well, we'll see how that goes. Thanks for this. Simi, you're at palamedicine.com. Can you just tell everybody where to find you if they want to follow you, if they want to visit your treatment center website, so on?
Oh, of course. Our website is palamedicine.com. We're on Instagram and LinkedIn and Facebook, I believe. And we are located in Pasadena, California. And yeah, it's what else can I say about this except follow us? We are, one of the things that I'm also working on is, as a pediatrician, very interested in this work with adolescents as well. Especially with chronically ill adolescents and adolescents who are at end of life. So there's a lot of, what would I say, messaging about this, to speak the language that of your workspace, which is, what's the story? What's the story of psychedelics? What will, in 5 years, looking back, what will we have achieved? By all this attention that we're paying to this, by all these resources that we're pouring into it, and how are those effects going to lay out over society and over just humanity as a whole? It is going to be a really active space of discussion and creation, I think.
Yeah, it is kind of cool. I think that with the history of generally with just psychiatric disease and mental illnesses. I mean, there are things like epilepsy was thought to be a psychological disease, and then later now it's obviously in the realm of neurology. Schizophrenia was there were all kinds of ideas about what causes schizophrenia, and it turns out that there's also a neurodevelopmental component of it. It is also, there's a neurological component to that too. So I think that I'm just really fascinated with this idea of facilitating neuroplasticity, like actually, having a system by which you can actually make it happen in adulthood. So I think
neurosurgery. It's like neurosurgery, right? Like sometimes it feels like that. Thank you, Dr. Z. I would be happy to facilitate a session for you. Please come on. Would love
it'll be fun. And hopefully it'll be a little less crude than the way that I did it when I was 19 or 20 or something like that. That was crazy.
Sure, we've got a little more finesse. And I have to give a shout out to my husband, Rob Matthews, who is the, kind of instigator behind all of this, because I would not have understood psychedelics without his, prior experience, but also understanding of what's required to create good psychedelic experiences. So I'm really leaning heavily on his expertise as a urban planner, experienced designer, and just around, really good healing presence. So, really grateful for being here.
Yeah, I would love to have both of you on and actually do a Q&A. So I think it'd be awesome. But anyway, thank you very much. Thanks to everybody for listening. Simi, can you stay on for just a couple of minutes after I finish this? But I appreciate everybody if you're listening to this if you're watching this on YouTube, please do like and subscribe. If you do that, this conversation goes up in front of more people. If you're listening to it on a streaming platform like Apple Podcasts or Spotify, again, please give us a rating, because that'll also help serve this to people who are interested in it. And I think, this turned out well. For saying fascinating discussion.
Thank you.
Yeah, there's a lot of, Sazia's saying this was amazing. She's saying she loves you, so very good. This is great. So this is this is fantastic. Please go check out all the information is in the description to this, so you can see the links and where you can follow Dr. Rahman on Instagram and on Facebook and her website for Palamedicine. But thanks everybody for listening. Appreciate it.
Thank you so much.